Hey everyone, this is Paul from Ortho Eval Pal. What I want to do now is do a little video about how to do an upper quarter screen, okay? And what I want to emphasize here is that this does not need to take a long time. So I know a lot of providers don't have a tremendous amount of time to spend with a patient, but if you're somewhat suspicious that they have some sort of a cervical spine lesion going on, it's very important that you do an upper body screen. And so I'm going to show you what I like to do. And you don't need to follow my pattern, but you need to follow a pattern. That's very important, okay? So kind of like a list in your head of what you like to do first, and then you kind of work off of that. And that way you kind of don't miss anything unusual, okay? So I will show you today what I like to do when I do a cervical spine screen and what works really well to help clear out all kinds of problems. And I won't just show it, but I'll explain it, okay? So the first thing I like to do is I like to go through reflexes, and this is the part where I kind of get familiar with the patient, so I might talk to them a little bit and say, hey, how's it going, where are you from, and what classes are you taking, and all that. And I'll start with C5, biceps, C6, brachioradialis, go over C7, triceps, come over this side, we're going to do biceps, sorry I'm in the way, brachioradialis, C6. We're going to do triceps on this side. And as you can see, Tony here doesn't have great reflexes, okay? But he's symmetrical on both sides. So that's the most important thing. Next thing I like to do is Otomo testing. So I'm going to have you spread those fingers apart. So we're going to do this as we go, okay? So we've got T1, spread those fingers apart. Don't let me squeeze them. Don't let me squeeze them. Don't let me squeeze. Don't let me squeeze. Good, that's nice and even. Now we're going to do C8. By doing an OK sign. So hold that tight. Don't let me open it. Don't let me open it. Great. We're going to do C7, triceps. Don't let me push the arm up. Good. Let's do this side. Don't let me push the arm up. Great. That's C7. We're going to do C6, which is wrist extension. So hands up like you're saying stop. You hold the forearm with one hand, push down with the other. Good. Hold here. C6. We're going to put the arms like this. We're going to do C5, okay? And remember I talked about in other videos that I like to do C5 by testing supination. Don't let me turn the wrist downward. Hold tight. Great. Good. You can also test them by testing the biceps. So hold like this. Don't let me push down. And don't let me push down. Good. The other thing that you need to recognize with C5 is that C5 controls the deltoids. So somebody can come in and look like they have a rotator cuff tear, but it's actually a C5 nerve root compression. And I have a great video that I'm going to put up, and it's super old-fashioned, but it's the reason why I developed the Marquis maneuver. So I'll have them do deltoids, abduction, hold tight, and I'll also do forward, flexion, hold tight. That's C5. Great. Now I'm going to have them keep the hands kind of like this, and we're going to do some sensory testing. C5, I ask them to tell me if they feel a difference between one and the other. Now this is very important. If the patient has a loss of sensation on one side and not on the other, and they say, okay, I don't feel it as much on this side, and then you go down to C6 and they say the same, they might mean the same as the last test. So I make sure that I am very clear when I say this, and I say, is this same or different, same or different, same or different, each time I test one, okay? So C5, same or different. And then C6, same or different. Dorsum of the middle finger, C7, same or different. C8, outer pinky. And T1, forearm. Okay? There we have muscle testing, reflex testing, sensory testing. All right? The next thing I'm going to do is a Sperling's test. So I'm going to take the head and neck, and I'm going to go in that direction, so you can stay right there. So I'm going to extend the neck, laterally flex him, and rotate him at the same time. So what I'm doing is I'm closing the facets on the left side. I'm closing the foramen, making that a little bit smaller. If there's disc material stuck in there, this will cause radicular pain down the arm. Now, if they only complain of pain up in the neck in a particular spot, it's more likely to be a facet problem. If the pain is going down the arm, it's more likely to be some radiculopathy coming from the cervical spine. Okay, I like the Sperling's test. It can help sort things out a little bit and tell us if there's some sort of radiculopathy going on or some sort of foraminal encroachment. I do the cervical spine compression test. I don't find this to be super sensitive, but if somebody's really flared up, they will get some increased radiculopathy going down the arm. When I do this, notice I just use my fingers and I put about 5 pounds of pressure. You should never get behind a patient and bear down really hard on the cervical spine, okay, unless you'd like to herniate their disc, which that's not what you want to do. The other thing that people who have a cervical spine lesion don't like to do is they don't like to extend their neck, especially if they're laying down in bed. Okay, so I ask them this question: when you lay down, how many pillows do you need to use? And typically, if they have a herniated disc, they jack themselves up with 2 or 3 pillows to keep themselves flexed. It just opens the frame and it takes pressure off the nerve root. Okay, next thing I'm going to test is I'm going to test his Hoffman's sign. Okay, so I'm going to take a hold of the middle finger. You need to relax your hand, really, really relax. I'm going to take a hold of the middle finger and stabilize the IP joint. I'm going to flick the finger, and I'm going to look for an approximation between the thumb and the index finger, kind of like this. And I have tons of videos with people who have positive Hoffman sign, so make sure that you just go to my playlist under Hoffman sign. You'll see a bunch of those and see what a real one looks like, okay? I test that. If somebody comes positive with a Hoffman sign, and maybe they are hyperreflexive, when I check their reflexes, I'm going to go down here and I'm going to do a Babinski sign. So I'm going to stroke the outside of the foot, turn in toward the big toe. As you can see right here, the toes go downward, okay, and that is good. That's what we want. If they extend and the big toe comes up, and it's usually delayed, that's a positive Babinski sign. You need to be worried about some sort of an upper motor neuron lesion. So if he's hyperreflexive, has a positive Hoffman sign, has a positive Babinski sign, I then check clonus, so I just basically dorsiflex the ankle really quickly, and if it continues to go, then I'm really going to be worried about some sort of an upper motor neuron lesion. So just because somebody has a problem at the cervical spine doesn't mean you shouldn't test the rest. This tells us a lot. I've seen a lot of patients with central cord stenosis in the cervical spine with all of these symptoms. They'll also feel out of balance when they're walking and be kind of discoordinated. Sometimes they'll have some bowel and bladder dysfunction. So you need to make sure you keep an eye on that. Another test you can do is if they have radicular pain, is cervical spine distraction. So you just lift straight up, and they'll typically say, you know what, my arm is feeling better. Or I'll put them on a table and I'll manually traction them. So that is a real quick and easy cervical spine screen. And the more of those that match together will help you identify, if that the lesion is some sort of nerve root compression in the cervical spine. If the pain is all localized around the neck, well, we'll talk about that in a little bit and talk about, how do you manage chronic cervical myofascial pain. Thank you.